Hello everyone, how are you doing? Today we will discuss on the common chronic disease, which is asthma. Asthma is a common chronic respiratory disease that we encounter at emergency OPD as well as at chronic OPD. So it is good to have a brief knowledge on this chronic illness. So this discussion mainly prepared from all these standard reference books. So it will brief you all the informations which are compiled in all of these books and the latest management protocols from GINA. Before that, we will see one case scenario which was seen at our health center, and after looking at that patient's evaluation and management, we will start discussing asthma, starting from the definition to latest management protocol of asthma, including acute exacerbation of asthma. So let's start with the case scenario. This is a summary of a patient evaluated for acute exacerbation of asthma. A 72 years old male non-hypertensive patient on losartan 50 mg PO daily and hydrochlorothiazide 25 mg PO daily. And he is a non-asthmatic patient on salbutamol puff and beclomethasone 1 puff PID. He was presented with exacerbation of shortness of breath of 1 day duration. Associated with it, he has productive cough with whitish sputum and chest tightness. He has visited emergency room 9 times for acute exacerbation of asthma over the past 1 year, and 3 of those exacerbations were over the past 3 of them were within this month. And the occupational history of the patient is not mentioned. On physical examination, general appearance, he was acutely sick looking, in respiratory distress. The vital sign, the blood pressure was 140 by 90 mm mercury, pulse rate 96, respiratory rate 26, temperature 36.9 degrees Celsius, and saturation was 86% of oxygen. Pertinent finding was on chest. There was a diffuse wheezing all over the chest, and there was no findings which are mentioned on cardiovascular system and that of the nervous system. And with assessment of acute exacerbation of asthma, he was investigated with random blood sugar 128 mg per day, and on CBC, WBC was 10,220, and with neutrophil 39.4%, lymphocyte 39.4%. Eosinophil was 15.8%, which is high and which is typical for asthmatic patient. And hemoglobin was 16 gram per day, and platelet was 241K. And with this assessment, he was treated with, he was put on intranasal oxygen and hydrocortisone 200 mg IV stat was given. Salbutamol puff 6 puff every 20 minutes for the first 1 hour. Then every 1 hour for the next 4 hours was given, and prednisolone was started 40 mg PO daily for 5 days. And after 8 hours of staying, he was improved and discharged. And there was no documentation of education on inhaler use. This is outline of our presentation. We start with the definition of asthma and end up with the management. The objective of this discussion is in order to have a clear picture on asthma, and finally in order to update you the latest management protocol of asthma. Asthma is a reversible narrowing of airways which results from exaggerated inflammatory response to allergen exposure. So from this definition we can easily get 2 important points. The first one is airway narrowing is reversible. Once we manage the patient, the airway will return to its normal state. That's why it is called reversible narrowing of airway. The second one is exaggerated inflammatory response. The major difference between asthmatic patient and normal patient is the inflammatory response is very exaggerated in asthmatic patient. Of course, the normal patients, when they get foreign body or infection, there will be inflammation, but that inflammation has its own limit. But in asthmatic patient, it's exaggerated, finally causing narrowing of the airway. So this is the most important point that we should mention in our definition, in the definitions of asthma. The next thing is acute exacerbation of asthma. Acute exacerbation of asthma means it is sudden, intense and continuous worsening of symptoms, and that also results in progressive worsening or declining in the underlying lung function. As you know, exacerbation of asthma can occur in patients with newly diagnosed asthma patients, or it can also be on a non-asthmatic patient due to poor adherence or inappropriate use of inhalers or other causes. Usually, in acute exacerbation of asthma, it's refractory to the ordinary beta-2 agonists, and in acute exacerbation, the patient might end up with mechanical ventilation. The next thing is epidemiology. This data is taken from Harrison21st edition, which was published in 2020, and from this book, we can understand that by 2020, the total of 241 million people worldwide are affected by this chronic respiratory disease, and this accounts about 4.3% of the total population. So the epidemiology based on the age, it's more common in pediatrics age group, contributing to 8.4% of the population group, and in adults it's about 7.7%. In terms of gender, in pediatrics age group, it's 2 times more common in boys, but in adults it's almost equalized, but there is slightly higher risk for females. When we see the mortality has significantly decreased since 1960. This is because of the development of steroids, either inhaled corticosteroid, oral corticosteroid, or IV corticosteroid has their own contribution in asthma control. That's why it results in a significant decrement on asthma mortality. Now let's come to the pathogenesis and pathophysiology behind asthma. There are a lot of inflammatory process taking place in asthmatic patients, but let's simplify it. All the important thing that we should know is what will happen in asthmatic patients. We don't have to memorize all the interleukins, the chemokines, or different prostaglandins and the like. So what will happen? It is clear. The allergen will enter into the airway, and the allergen in the airway, it will bind to immunoglobulin E, IgE. The IgE is already bound to the mast cell. So the mast cell is the one which contributes for the exaggerated inflammatory process. So mast cell will release histamine, prostaglandin, different cytokines, chemokines. All this process will result in 4 things. So knowing those 4 things is enough in order to understand the pathophysiology behind asthma. So what are those 4 things? One thing is the mast cell release histamine, and that histamine stimulates the bronchial smooth muscles. So that smooth muscles will become contracted and causing bronchoconstriction. That bronchoconstriction narrows the airway. That's one way of narrowing of the airway. The second one is different chemokine, cytokine cause different inflammatory cells. Almost every inflammatory cell is involved, be it neutrophil, monocyte, antigen presenting cells, T helper cells. So all this will migrate into the airway wall and causes continuous release different chemokines and cytokines. So when there is inflammation, there will be what? Edema. So that edema will further narrow the airway. The second mechanism. The third mechanism is just stimulation of the goblet cells. Normally goblet cells are found in the airways, and they produce mucus in order to trap and expel any foreign body and infections. But here the goblet cells become hyperplastic and their activity also increase. So increase in mucus production will result in what? Mucus plug. So the mucus plug will block the in and out movements of the air. This is the third mechanism. And the fourth one is different factors are released causing angiogenesis and vasodilation. So that will cause increasing blood flow to the airway walls, so it will cause vascular congestion, and that vascular congestion causes airway narrowing. So we have mentioned 4 mechanisms in general. Let's summarize them. One is bronchoconstriction due to smooth muscle cell contraction. The second one is increased in mucus production. The third one is edema due to inflammatory process. The fourth one is vascular congestion because of vasodilation and angiogenesis. All these 4 processes are known as airway remodeling. So that airway remodeling causes airway narrowing. That airway narrowing will cause the development of symptoms like shortness of breath, cough, chest tightness, wheezing, and the like. So this is the pathophysiology behind asthma. Almost this process takes place starting from the trachea up to the bronchioles, but it is more severe on the cartilaginous part of the airway, especially the bronchus. That's why it's usually called bronchial asthma. So this is important thing we should know under the pathophysiology of asthma. The next thing that we should know is the risk factors. This is because the management of asthma includes removal of modifiable risk factors. So we should know what are the risk factors for asthma. The risk factors generally can be classified as endogenous risk factor and environmental risk factor. Endogenous risk factors are risk factors which arise from the patient condition himself. This includes the first one is atopy. Atopy means it is a localized hypersensitive reaction to allergen. For example, allergic conjunctivitis, allergic rhinitis, allergic dermatitis, and the like. So this is the most common risk factor for asthma. So patients with atopy are at increased risk of asthma. For example, asthmatic patients, almost 80% of them has allergic rhinitis. It's the same is true for allergic dermatitis. So atopy is most important endogenous risk factor. The second endogenous risk factor is childhood infections, includes like viral infections by respiratory syncytial virus and that of adenovirus, especially virus which causes bronchiolitis, increases future risk of development of asthma. The other infection is infection caused by atypical bacteria like chlamydophila and mycoplasma, increases future risk of asthma. The third endogenous risk factor is obesity. Especially in obese patients, the risk of asthma is high. The second one is the risk of exacerbation is high. And the third one is the risk of even severity of exacerbation is high. Patients with body mass index of more than 30 kg per meter square. Other endogenous risk factor includes gender, which I have mentioned in the epidemiology part. The other thing is obstetrics history, like teenage pregnancy, prematurity, low birth weight. All these are associated with poor lung development, and finally end up with poor underlying lung function. So their future risk of development of asthma will be high. The second important risk factor is environmental risk factors. So one is smoking, be it passive smoking or active smoking. Other thing is associated with diet, like lack of vitamins, vitamin A, C, D, E, and electrolytes like magnesium, selenium, and the like they are important antioxidants, so the risk will be higher. The other environmental factor includes occupational risk factors. Different occupation predispose a patient to different allergens, so that continuous exposure to certain allergens will result in the development of asthma. Usually in occupational asthma, the patient gets relief during the weekend times. The other environmental risk factor is associated with pollution, be it indoor or outdoor pollution. Indoor pollution due to combustion fuel, outdoor pollution due to different gases released from factories and other machines. Then the next thing is triggers. Triggers means the one which immediately initiates the inflammatory process. That's one and most common thing is allergen. The allergen can be pollen, it can be dust, animal furs. The next thing is its infection is the second one, be it viral infection or bacterial infection. Exercise is another important trigger, and usually it is relieved after, usually it starts after 30 minutes of exercise. Medications can be important triggers, especially aspirin, beta blockers. Foods like food colors and different packed foods are important triggers. The other thing is hormonal changes, especially in different stages of menstrual cycle. When the progesterone level is low, then asthmatic symptoms may start or patients may develop exacerbation. Stress is also another important triggers for asthma. So we need to know all these triggering conditions. The next thing is that we should discuss is comorbidities. The reason behind is patients with these comorbidities, one thing is asthma control is difficult. The second one is the severity of exacerbation is higher than patients without these comorbidities. So these comorbidities include, one is COPD, the other thing is underlying cardiac illness. The other thing is patients with laryngeal edema, laryngeal tumors, patients with obstructive sleep apnea, obesity, and GERD. And the other thing we need to know is differential diagnosis for asthma. As you know, patients with asthma present with cough, chest tightness, shortness of breath. So these symptoms can also be seen in patients with cardiac asthma. But how do you differentiate from the bronchial asthma? By cardiac findings. In addition to that, there will be bilateral or lung field cryptation. Other important differential diagnosis is COPD. Especially in COPD patients, we can differentiate from asthma. One is history, the one with chronic cough and absence of wheeze, and symptoms in asthma usually exacerbate or worsen during early in the morning and during the night time, while in COPD patient it's almost the same and usually it worsens with exertion. And patients with laryngeal edema, laryngeal tumor may have these symptoms. Foreign body aspiration, but in foreign body aspiration the patient will have a focal wheeze. Another differential diagnosis, bronchiectasis, especially bronchiectasis in developing countries, it results from previous tuberculosis infection. And tracheobronchomalacia. All these are important differential diagnoses that we should consider while evaluating a patient presented with asthmatic symptoms. Now let's see how to approach asthmatic patient. One thing we should know is the diagnosis of asthma is clinical, but spirometry helps us to confirm the diagnosis. So it solely relies on our history taking and physical examination. So we should carefully take the history and we should do a skillful physical examination. So by simply doing these two, we can diagnose asthma. Let's start with history. On historical part of a patient, the most important thing we need to evaluate is symptoms. So as you know, the typical symptoms of asthma includes, one is increased chest tightness, wheezing, cough which worsens with exertion, and also rapidly progressive dyspnea. So these are the typical symptoms which are seen in asthmatic patients. But after taking this history or after characterization of the symptoms, always we should keep in our mind the differential diagnosis that we have discussed earlier. We need to rule out or rule in the above differential diagnosis. And the typical feature in asthma is these symptoms usually worsen during the night time and early in the morning. So this is the way how we characterize the symptoms. After detailed characterization of the symptoms, we need to search for the risk factors that we have discussed earlier, either endogenous risk factor or environmental risk factor. This is because some risk factors are modifiable, and even most of the risk factors are a cause of acute exacerbation in the future. So the patient should avoid those risk factors. In order to avoid the risk factors, first we need to evaluate, or we need to search those risk factors from the patient. After exploring the risk factors, then we need to assess the patient medical history. If he was a non-asthmatic patient, his adherence to the drug, because poor adherence and poor use of inhalation or poor techniques of using this short-acting beta agonists or using of inhaler results in poor control of asthma. So in order to avoid that, we need to search, or we need to evaluate patient's adherence to the drug, and also the way he is using. Previous history of hospitalization, emergency room visits, previous history of ICU admission are important history, because future risk of exacerbation increases with previous history of exacerbation. So we need to assess all these things. And in general, other medical, surgical histories, social, personal history should be evaluated. The other thing is symptoms of complications. What are the common complications of asthma? Common complication of asthma includes dehydration, especially in pediatrics age group. The other common complication is cor pulmonale. Features of or symptoms of cor pulmonale, shortness of breath is there, but in addition to the asthmatic symptoms, the patient will have abdominal swelling, peripheral or generalized body swelling. So this is additional symptoms we need to assess on while considering the complications. The other is features of or symptoms of anoxic brain injury, tussive syncope, presence of pneumothorax, respiratory tract infection, and respiratory failure. All these things should be assessed on the historical parts of asthma. After taking history, we need to do the physical examination. So physical examination begins with general appearance. So in general appearance, what do we expect in asthmatic patient? Most likely, especially if the patient visits emergency room, we don't expect him to be a stable patient. Rather, the patient might be acutely sick looking because of the respiratory distress. He may not even finish a sentence, phrase, or words while taking the history. So this will tell us a lot about the severity of the respiratory distress. So the most important thing in the physical examination part of asthmatic patient is vital signs. Vital sign helps us to decide on patients who need ICU admission, and in the lower health tier systems, and for patients who need immediate referral. So by looking at just simply these 5 components of the vital signs, we can make early decision. We start with blood pressure. What do we expect on blood pressure? The most important thing is the presence of pulsus paradoxus or wide pulse pressure. This wide pulse pressure usually results from the presence of hypercapnia, which is seen in asthmatic patient because it's obstructive lung disease. The second thing is pulse rate, tachycardia. The tachycardia results from what? Again, from the hypercapnia. And on the respiratory rate, patient becomes tachypneic. Why? Because the patient is in hypoxic state. Even there might be also acidosis. All this results in tachypnea. And patient might be febrile. It doesn't result from the asthma itself, but rather due to concomitant pulmonary infections, because pneumonia, upper respiratory tract infection, all these are among the most common asthma triggers. And the other thing, saturation. Patient, especially in CV form of acute exacerbation, patient may not maintain saturation. So saturation might be less than 90%. On HNT, patient may have allergic conjunctivitis, allergic rhinitis, and the presence of concomitant nasal polyp, especially in patients with adult onset asthma. They have concomitant nasal polyp, the one which you call it intrinsic form of asthma. On chest, this is among the systems the one which holds a lot of pertinent findings. So on inspection part, we may get use of accessory muscles because of the respiratory distress. The other thing is paradoxical inward movement of the chest, the abdomen due to contraction of the diaphragm. The other thing is on percussion, presence of hyperresonance, which results from pneumothorax or the presence of hyperinflation. And on auscultation, the presence of wheezing, even crepitation can be there because of concomitant pneumonia. In severe form of acute exacerbation of asthma, there might be silent chest. So always absence of wheeze doesn't confirm absence of asthma. So in severe stage, when there is complete obstruction of the airway, there will not be wheezing, rather there will be silent chest. On cardiovascular system, we need to search features of core pulmonale, and on abdomen we may get hepatomegaly and ascites because of the core pulmonale. On integumentary system, allergic dermatitis, eczema can be there. And the last component of our physical examination on nervous system, Glasgow coma scale should be assessed. Patient might be confused, or there might be obtundation because of the hypercapnia and hypoxia. So by doing physical examination and by appropriate history taking, we can diagnose asthma. Finally, based on our history and physical examination, asthma can be classified into 3: mild asthma, moderate, and severe. The mild one can be mild intermittent or mild persistent, and there is moderate persistent and severe persistent. This classification depends on 3 factors. The first one is daytime symptoms. So we will see the frequency of daytime symptoms. For example, if the patient says, I have experienced these symptoms almost 4 times per week during the daytime, then the severity class will be on step 2, which is mild persistent, because they done daily but it's more than 2 times a week. And we will assess the nocturnal symptoms. So for example, if a patient says the presence of those symptoms almost 1 times a week, then the severity class become moderate persistent, because in moderate persistent it's more than 1 time a week. So this is the way how we classify severity of asthma. The last one is it depends on the spirometric finding, which is the ratio of FEV1 to FVC. Classifications of severity of asthma depending on daytime symptom, nocturnal symptom, and spirometric features. And the table is taken from MedStar Clinical Synopsis of Internal Medicine, which was written by GINA University 2023 graduating class. The other classification of severity of asthma is the one which is suggested by GINA. GINA is, as you know, it's Global Initiative for Prevention of Asthma, and this classification is the preferred one. If we compare it with from the previous one, this is the preferred classifications of severity of asthma. This classification depends on retrospective classifications of asthma, which means first we will diagnose asthma and we start management, and we have different options of treatment on the table. So based on those treatment options, we will manage the patient, and the degree of or the steps of treatment that's required for the patient symptom control. Based on that requirement, we can classify the patient to either of these severity groups. For example, mild asthma is when the asthma is well controlled with low intensity treatment. For example, if the patient symptom is controlled by simply giving salbutamol puff per needed plus low dose ICS per needed. That means with low intensity treatment, the symptom is controlled. The one which we call it step 1 and step 2 treatment. These are the low intensity treatment according to the GINA. So if the patient symptom is controlled by these amounts of treatment, then it's classified as mild asthma. The second one is moderate asthma, when the asthma is well controlled with step 3 and step 4 treatment. Step 3 and step 4 treatment is maintenance doses, either low dose or medium dose, but It is maintenance. Maintenance means the patient will take routinely, not per needed. And we say severe asthma when the asthma requires step 5 treatment, high dose ICS LAVA. The maintenance dose is high dose, or we may also combine other bronchodilators and anti-inflammatory drugs. Most important thing is we need to know the difference between severe asthma and uncontrolled asthma. Always before saying the patient has severe asthma, we need to rule out uncontrolled asthma. Uncontrolled asthma is not severe asthma, because uncontrolled asthma is the asthma might be mild asthma. The problem is the patient is unable to control it. Why the patient is unable to control his symptoms? One is, the most important thing is non-adherence. If he is not taking his medication appropriately, the severity of the asthma might be mild, but because of his non-adherence, it might seem severe asthma. But rather than classifying the patient to severe asthma, first we need to rule out uncontrolled asthma. So what are the causes of uncontrolled asthma? One is poor adherence to inhaled corticosteroid or oral corticosteroids. The second one is inappropriate use of inhalers. And the third one is the presence of comorbidities like obesity, obstructive sleep apnea, GERD. All these are associated with or results in uncontrolled asthma. And the fourth one is wrong diagnosis. Patient might not have asthma, or wrongly patient might be diagnosed with asthma, but the underlying problem might be the one which I have discussed earlier under differential diagnosis for asthma. So wrong diagnosis by itself results in features, or you may consider as uncontrolled asthma. So first we need to rule out all these things. After ruling out all these things, then the condition of the patient doesn't result from uncontrolled asthma, rather it's severe asthma. So we need to manage by step 5 treatment. And this is classification of severity of asthma exacerbation. Don't be confused. The previous one are simply classifications of asthma, which means when we manage a patient in chronic OPD, when the patient is stable or free of exacerbation, asthma classified as mild, moderate, and severe. This one is the severity of exacerbation, which means when the patient comes to emergency room due to acute exacerbation of asthma, we need to classify the patient's condition into mild, moderate, severe, or impending respiratory failure. This classification doesn't affect anything. The only benefit of this classification is in order to make decisions on management options at the time of exacerbation. It doesn't affect our future management. So in case of severity of asthma exacerbation, it depends on the symptoms and the signs. So from the history, the degree of breathlessness and speech is most important features we need to consider. Under the sign includes like the body position of the patient, the respiratory rate, presence of breath sound, the use of accessory respiratory muscles, heart pulse rate, blood pressure, and mental status. So by assessing all these things, we will record and we can classify the patient as mild, moderate, severe, or impending respiratory failure. If the patient has features of severe asthma or impending respiratory failure, we need to be ready for ICU admission. We take history, we do physical examination, we classified the patient or stage or severity of asthma, and in case of acute exacerbation, we classified the severity of acute exacerbation. By doing this, we can investigate the patient. The basic investigation we need one is CBC. It's basic investigation. On CBC, we may get features of infection. In case of pneumonia, there might be leukocytosis with left shift, and additionally in asthmatic patient there is typicals of eosinophilia. As you can see on our case, the patient has eosinophilia of about 15.8%, which is high. This is one of evidence of asthma. Then we need to check the random blood sugar because it's among the life-threatening conditions. Hypoglycemia is among the life-threatening condition. Then the next thing is spirometry. Spirometry, of course, usually it's found in the best facilities, and usually it needs a pulmonologist in order to do it. So spirometry is confirmatory diagnosis for asthma, and whenever available we need to do that. Arterial blood gas analysis, of course, it's also found in the best setups, and if available it's good to do arterial blood gas analysis, and it helps us to decide for patients who needs ICU admission, because hypercapnia, acidosis, all these things will help us to for early decisions of intubation. Other important investigation is chest X-ray. Of course, in asthmatic patient, usually it's normal, but we may say features of pneumothorax, which is complication of asthma, and hyperinflated lung will be there. Sometimes there might be consolidation because of pneumonia. And ECG is important investigation. On ECG, evidence of cor pulmonale can be identified, and provocation test and skin allergen test helps us again to confirm the diagnosis. In order to search for the allergen, we do skin allergen test, and provocation test is usually to confirm the diagnosis of asthma, and it's not routinely done because of the dangerousness of the procedure, and it needs pulmonologists for this test. So this is the way how we investigate a patient. While investigating a patient, always we should start management. We shouldn't forget that whenever a patient comes to emergency room with acute exacerbation of asthma, the most important thing is ABC of life, because these conditions may result in life-threatening conditions. One is airway, because patient might be confused and may not be able to secure his airway. The second thing is we need to assess whether the patient is breathing or not. So if he is not, immediate intubation should be considered, and circulation is also important. That's why we need to assess the pulse rate and the blood pressure. After initial evaluation and management of a patient, so our management goal is, one is immediate relieving of the symptoms. So controlling the symptom is relieving the symptom is the most important thing. The next thing is for future controlling of symptoms, future controlling of exacerbation, and prevention of complication are our management goals. So in order to achieve this management, we have two options of management: non-pharmacologic management and pharmacologic management. Non-pharmacologic management is the one which we need to do during exacerbation. Whenever a patient comes to hospital due to exacerbation, the most important or initial thing we need to do is admission. So initial management is at emergency room, we need to stabilize the patient. If the patient is unable to stabilize, we need to transfer him to ICU. If you are at health center or at a primary hospital when resources for management of asthma are not available, so we need to consider referral. But if we are in hospital setup where there is ICU, and if the patient is unable to stabilize at emergency room, we need to transfer him to ICU. Or if the patient stabilizes, we may transfer him to the ward. So this hospitalization is the first thing we need to do in case of acute exacerbation. Then the second important thing is oxygen therapy. So for oxygen therapy, we may use nasal cannula or face mask. And our target saturation is more than 92%, but there are special group of populations like patients with underlying cardiac disease, and in case of pregnancy, our target saturation is more than 95%. So oxygen therapy is the second non-pharmacologic management of acute exacerbation of asthma. And the third thing is positioning the patient. Forward leaning posture is the preferred position for asthmatic patients. And fourth one is hydration. And hydration is for replacement of insensible losses, and we can use normal saline. So after we stabilize a patient with those non-pharmacologic management options, then concomitantly we should start pharmacologic management of asthma. What are our options for pharmacologic management of asthma. There are three classes of drugs on the table. The first one are generally bronchodilators. The second one is steroids, and the third one is antibiotics. Antibiotics is optional. It's not a routine treatment for asthmatic patients. The bronchodilators includes majorly three groups. This includes one is beta-2 agonists. The second one is anticholinergics or antimuscarinics. The third one is aminophylline. Now let's discuss about these drugs. Let's start with beta-2 agonists. The mechanism of action of these beta-2 agonists is by stimulating the beta-2 receptors which are found on the airway walls and on the airway smooth muscles. It will result in relaxation of the airway smooth muscles, and it will also inhibit the exudation and edema, and it will also increase the mucociliary functions, and it will clear the exudates as well as the mucus, which results from the exaggerated inflammatory response. So the mechanism for administration of the drug is one is inhalation. So for inhalation we may use the meter dose inhaler, the one which you can see on the picture, and the other thing is we can also administer by using a nebulizer. And these beta-2 agonists are two types based on their duration of action: short-acting beta-2 agonist and long-acting beta-2 agonist. Let's start with short-acting beta-2 agonist. We can call them SABA. This includes salbutamol, albuterol, terbutaline. These are the drugs which are classified under SABA. They have rapid onset and their duration of action is 3 to 6 hours. And they are used as needed, usually for symptom relief. Their common side effect is tremor and palpitations. So how do we administer these drugs? Whenever a patient comes to emergency room due to acute exacerbation of asthma, commonly we use salbutamol puff. So this salbutamol puff is given, it's simple. We can give 4 up to 6 puff every 20 minutes for the first 1 hour. Then we can administer hourly for the next 4 hours. So by this way we can stabilize the patient. The second one is LABA, long-acting beta-2 agonist. This class of drug includes salmeterol and formoterol, and they are called long-acting because their duration of action is over 12 hours, and they have replaced the regular use of SABA. But we shouldn't forget that LABA is always should be used in combination with inhaled corticosteroid, because the LABA is its bronchodilator and the inflammation should be controlled. The inflammation is controlled by additional administration of corticosteroids. So LABA should be used with ICS, inhaled corticosteroid. If not, control of asthma is difficult. The other thing is non-selective beta-2 agonists. These non-selective ones usually used as a last resort medication. Epinephrine can be administered subcutaneously. The second class of bronchodilators includes anticholinergics. We can also call them antimuscarinics because it will antagonize or oppose the muscarinic receptors which are found on the airway. This group of drugs includes like ipratropium bromide, and the major mechanism of action is by blocking of cholinergic nerve-induced bronchoconstriction and mucus secretion. And it's less effective than beta-2 agonists. That's why usually it is used in combination with beta-2 agonist whenever control of asthma with inhaled beta-2 agonist is not achieved. The third group of drug includes aminophylline. Aminophylline is nowadays it's not widely used. The reason behind it, it's narrow therapeutic index for treatment because it's associated with those side effects. It may result to the level of arrhythmia, epilepsy, and up to death. For that reason, it is used as a last resort after 24 hours of management of the patient. And magnesium sulfate is also used in case of acute exacerbation of asthma because it's a bronchodilators. So these are the three group of bronchodilators we should always keep in our mind while learning or while studying asthma. So after discussion of bronchodilators, the second group of drugs used in asthmatic patients is steroids. So it's straightforward. They are anti-inflammatory agents because asthma is exaggerated inflammatory process. So we need to reverse that inflammatory process by the administration of steroids. Steroids can be administered in three ways. The first one is ICS, inhaled corticosteroid. The second one is OCS, oral corticosteroid. And the third one is, again, intravenous corticosteroids. So, IV and oral corticosteroids are usually used in case of acute exacerbation and used for short course for controlling of acute exacerbation. The reason behind this the side effect in systemic steroid is very wide and they are dangerous drugs. So when they are used for prolonged period of time, they can result in truncal obesity, bruising, osteoporosis, diabetes, hypertension, gastric ulcer, different types of infection, depression, cataract. All these things are results from prolonged use of systemic steroid. For that reason, don't forget oral corticosteroids and IV corticosteroids are used in case of acute exacerbation for short course of treatment. For example, prednisolone after exacerbation, we may use it for 5 to 10 days and we can stop it without tapering. And IV corticosteroid like hydrocortisone and methylprednisolone can be administered when the patient comes to emergency room due to exacerbation. So steroids are important drugs on the table for asthma management. For prolonged control of asthma, the preferred route is inhaled corticosteroid because the side effect is limited to the airways. Commonly, it will result in candidiasis or upper respiratory tract infection as well as pneumonia because the immunity become weak. Otherwise, the systemic will decrease in case of inhaled corticosteroids. The third drug which are used in management is antibiotics, and it's optional. It's used whenever there is evidence of infections like pneumonia. Almost 4% of all patients who are hospitalized for acute exacerbation of asthma requires mechanical ventilation. There are clear indications for mechanical ventilation. One is clinical evidence of impending respiratory failure like coma, respiratory arrest, exhaustion, confusion, drowsiness, and the like are clear indications. The other thing is if arterial blood gas analysis is available, the presence of or evidence of hypercapnia, hypoxia, acidosis are among the indications for mechanical ventilation. This treatment algorithm is taken from UpToDate and it will help us in decision making while managing a patient. So ICU admission criteria: presence of altermentation, exhaustion, decreased air entry, and any abnormalities on the arterial blood gas analysis are evidence or criteria for ICU admission. So after managing a patient at emergency room, then we need to follow or monitor the patient condition. The two important evidence are: the first one is following the vital sign of the patient. The second one is clinical features, which is history as well as findings, especially chest findings are important for monitoring patient condition. If available, arterial blood gas analysis and spirometry also may help us in monitoring patient's condition. So upon discharge, these medications and plans are used. So this includes use of short-acting beta-2 agonist, and oral corticosteroids should be continued for 5 to 10 days. And concomitantly, we should start also inhaled corticosteroid. We need to educate the patient about the inhaler, and we need to develop written action plan and appoint for follow-up visit. These are the goals of asthma therapy, and this treatment plan is taken from GINA 2024. In management of asthma at chronic OPD requires this circle. The first one is assess, then adjust, then review. What do we assess? We need to assess. One is symptoms control and modifiable risk factors, the presence of comorbidities, the inhaler techniques and adherence. All this should be assessed. Then after assessing these conditions, we need to adjust the treatment of modifiable risk factors and comorbidities and non-pharmacologic strategies, asthma medication including ICS, education and skill training. All this needs to be adjusted. Then we need to review the symptoms, exacerbations, side effects, lung functions, comorbidities and the like should be reviewed. So after doing this, we can choose two tracks, track 1 and track 2. The preferred one is track 1 and track 2 is alternative. The reason why we choose track 1 is because the future risk of exacerbation is very low compared to track 2. So the only difference between track 1 and track 2 is step 1 and step 2 treatment. Otherwise, starting from step 3, it is the same for both of them. In track 1, or the preferred management plan is track 1, as I've mentioned. In step 1, we use two drugs combined. Two drugs. These are ICS with LABA, long-acting beta-2 agonist. For example, fluticasone with formoterol or beclomethasone with formoterol. If we use as needed, it's step 1 and step 2 management, especially in case of mild asthma. Step 1 and step 2 management is enough. In case of moderate asthma, step 3 and step 4 are the management options. In step 3 and step 4, we use low dose or medium dose maintenance ICS with formoterol. And in case of severe asthma, we use step 5 management, which is in addition to high dose maintenance ICS with LABA, we add LAMA or anti-interleukin 5, anti-IgE and the like. So this is track 1. In case of track 2, step 1 and step 2, we use, rather than LABA long-acting beta-2 agonist, we use SABA short-acting beta-2 agonist, especially in developing nations. We use salbutamol puff per needed in step 1, and we use ICS whenever salbutamol is used. In step 2, we use low-dose maintenance ICS and combined with salbutamol puff per needed. Otherwise, step 3 and step 4 and step 5 management is the same as that of track 1. So all general practitioners who are working at chronic OPD should know this management protocol. And the mortality in case of asthma is very low. Mortality is high, especially in patients with other comorbidities like patients with underlying heart failure and chest deformities and other underlying pulmonary pathologies. In addition to that, in smokers, the risk of mortality is high. Lastly, these are the reference books I have used to prepare this slide. So by watching this video, you have gathered all the informations which are included in these books. Lastly, we will see a video showing on how to appropriately use inhalers, because inappropriate use of a metered-dose inhaler is a common cause of acute exacerbation of asthma and poorly controlled asthma. So in order to avoid that, every physician, every medical professional should know how to use inhalers and should teach their patients on how to use those inhalers. So this is the video showing on how to appropriately use inhalers.